This week on Inside Olympia, what will it take to create a robust and comprehensive behavioral health system in Washington? Why is it taking so long to get there? And what are the barriers to success? On the program for the full hour this week, Amber Leaders, co-chair of the Joint Legislative Executive Committee on Behavioral Health.
From the TBW studio, it's Inside Olympia with host Austin Jenkins.
And welcome to Inside Olympia. From deinstitutionalization in the 1970s to present-day efforts to better serve psychiatric patients in the community, the journey to build a behavioral health system in Washington state that respects the rights and dignity of individuals while also getting them the help they need has been a challenge. Now, a joint legislative and executive committee on behavioral health is working to bring a more strategic approach to mental health care in the state. Why now? What are the committee's responsibilities and goals? What will the end product be? And what hope should patients, families, and Washington state citizens have that a better system is coming after so many decades of falling short? Joining me now, and for the full hour this week, is Amber Leaders, a senior policy advisor in the Office of the Governor and co-chair of the Joint Committee. Welcome to the program. Nice to see you.
Nice to see you. Thank you for having me.
And thanks for talking about this important issue. And it's nice that we have the full hour to do so because it is complex. There is a long history here, and it's not as if there's an easy point in time to begin the conversation. But let's just step way back to the 30,000-foot view and ask the question, what is the purpose of this joint effort by the legislative branch and the executive branch? What is this joint committee supposed to do? What's your charge?
Yeah, I think the primary charge of the committee is to do exactly what you just described, which is to come up with a strategic plan and a strategic vision for behavioral health. As you know, there's been a lot of work in the state of Washington over at least the last decade, probably longer, to really address the behavioral health needs of Washington citizens. And one of the things that continually comes up is how do we do that in a more cohesive, cross-system kind of way? And there's been a continuing call for, well, what is our vision? If we want to design a behavioral health system for Washington state that really works for people and their families, what does that look like and how do we get there? And I think the primary charge of the JLEC is to bring legislative and state agency experts together to really think about what is that strategic vision.
I know you were serving as the co-chair. It wasn't necessarily your brainchild to come up with this, and you don't hold the responsibility of decades of perhaps shortcomings in this arena on your shoulders alone. But one might wonder, why just now are we doing this when there have been there were so many opportunities earlier on to try to get those silos to break down their walls and start to create something cohesive? Any insight into why it's happening now and didn't happen 5, 10, 15, 20 years ago?
Yeah, one of the things I would say is that I think it has happened some before. We've had a number of committees in place. For example, earlier in the 2010s, there was the Select Committee on State Hospitals, which really took a more focused look on what are we doing with our state hospitals and how are we moving to more community-based care. After that, there was a committee known as the BURST, which was the Behavioral Health System Transformation Committee, which also took a look at this. And so I think there's been continuing efforts to do exactly this, to try to bring that sort of strategic vision. And one of the things, I've been with the governor's office since 2019 now. One of the things that I think is a big challenge is that the behavioral health system is so large that it's very hard to get your arms around a comprehensive vision. But you're starting to see a more concerted effort to do that. The Children and Youth Behavioral Health Work Group has also taken on a strategic plan specifically focused on children and youth. And this really comes in on the heels of that, seeing some of the success of the Children and Youth Behavioral Health Work Group to really build out a more comprehensive strategic plan.
Well, if that's the case, that to some extent, and in point of fact, part of the work that's been done, early work with this committee, is to document how many groups there have been and entities have been set up to look at this, and it's multiple pages. And there's the SQUISH, there's another one.
Yes, that's the Select Committee on State Hospitals. That's the SQUISH.
That's the one you were, okay. Yep. So yeah, there's these different acronyms. But what is different this time around, or why do you think this particular joint legislative executive branch committee might be able to succeed where others did not in taking a more comprehensive, fulsome, holistic view and look?
I think a couple of things are different from my knowledge of how these committees have worked before. One is that this is a really comprehensive committee. It's modeled after some of our other joint legislative executive committees where you're really bringing those two branches of government together to work in partnership. The legislature also appropriated some dollars to help support in terms of not only staff, but as well as a contracted facilitator to really help us through the process of building a strategic plan and doing that work. And I think some of the hope of the committee is that this committee might do some additional work in terms of stakeholder outreach, subcommittees, work group, community buy-in on a plan, which is one of the things that I think, again, looking to the Children and Youth Behavioral Health Work Group, that they have done very well. They really have built a coalition not only of state government individuals, but of people, families, people with lived experience, community providers, to really put these important plans together. And I think that's one of the things that we hope to accomplish with some additional time with this group.
I should note that this joint committee has members of the legislature on it. It has executive branch agency directors or their designees, and it also has a couple of individuals who are directly impacted and living with behavioral health conditions to represent the perspective of patients and individuals. You also have you mentioned the facilitator. There's also a private group that is helping you on the data side of things, Athena. Can you explain kind of their role and how that's going to augment the work?
Sure. Yeah. Athena Group is a contracted facilitator. They're doing the facilitation.
Oh, so they're doing the facilitation. Okay.
Yes, and they're also going to do the data work. And part of what they're going to do is that they are doing work with our research and data analysis unit at the Department of Social and Health Services, as well as working, part of their task is to work with entities like the Caseload Forecast Council and other sort of data entities to try, if not bring the data together, tell us what the gaps are and how do we build a more complete data system so we can be more predictive, more nimble, better adaptable to what we need to build for the behavioral health system.
Yeah, and for the future.
And for the future.
So another kind of data point or point in time, I was on the grounds of Western State Hospital in 2018 when Governor Inslee announced a 5-year transformation of the behavioral health system, which contemplated building this forensic center of excellence on the grounds of the state hospital to treat people coming through the criminal justice system, and then a shift of civil patients, those who are brought in on civil commitment but not through the criminal system, to serve them out in the community. We've now passed the 5-year period, if my math is correct. And one might also say, well, wait a second. In 2018, the governor was announcing this transformation, but now we've got this new joint committee trying to, again, it seems, transform. So help us understand the last 5 years under the governor's initiative and how that fits into what's going on now.
Sure. So as you note, there's been this plan to do sort of a transformation of the behavioral health system, and that's been really a focus of moving away from some of our institutional care, moving away from some of our deep end systems. People often cycle through our emergency rooms, through the criminal justice system, through being unhoused, and trying to move into more community-based care. That there's been build out of a number of facilities, work to integrate behavioral health as part of our insurance systems, all kinds of things. There's been the advent of the 988 system to build out more crisis services, all kinds of things to really move us towards that community-based option of care. And I think part of what this group is doing, if you look at the language in the proviso, is talking about continuing on that vision of moving us further upstream as a state, getting more to things like prevention, early intervention, and crisis services, trying to contact people before they get into those deep end systems of care. And it's one of the things the proviso calls out specifically in terms of the strategic plan, which is building out a plan that does exactly that and puts an emphasis on how do we really continue building towards community-based behavioral health.
Well, a cynic might say, gosh, we're just reinventing the wheel over and over again here. From your perspective, though, how does the work of this committee build upon the effort to kind of separate out forensic from civil, treat the forensic patients to the extent necessary in the hospital setting, get the civil patients out into the community? Like, to the extent that that transformation has a lot of it has happened, where now do you think this committee can kind of help with the next few steps?
Yeah, I think one of the big roles of this committee is continuing to move us on that path to some of the investments that we really need to make in the earlier parts of the system.
So if to some extent, if the system was built around dealing with people, as you kind of use the term, the deep end, now, and so now this sort of realignment's happened, now there's an opportunity to come into the back end and start to say, well, could we catch people sooner and earlier?
I think that's right. I think that's exactly right. I think the initial vision of the governor is moving us away from the state institution model, which is state-operated beds, large state hospitals, hundreds and hundreds of beds, and moving to these smaller community-based models and building out. But even that was sort of talking about long-term inpatient capacity, and that's just a small sliver of the behavioral health system. And many people don't need that level of care, long-term inpatient. Some do, and we need to make sure that capacity is available. But a lot of individuals, what they really need are those earlier interventions. How are we providing behavioral health to our youth in our schools? How are we making sure young adults, when they're 18 to 25, are getting access when they have that first episode of psychosis? How are we building out our substance use system? I think this is building on that vision into that more comprehensive look of how do you really build in those early interventions so people don't go to those very deep, long-term behavioral health services unless that's what they really need.
The podcast, The Lost Patients, that KUOW produced earlier this year, there was an analogy in that, and that looked at the history of this broken system in many ways, sort of fractured system. I suppose some would say broken, others might use a different term, but a system that hasn't necessarily served patients well and holistically. And I think the analogy was, it was like somebody built a house, but none of the floors or rooms actually connect. And so it doesn't make you walk in and it doesn't make sense. Using that sort of image, if this is the house this committee has inherited, and maybe some things, maybe somebody got in there and connected some things and it's not as fractious as it was initially, where do you go from here in terms of trying to make that house make more sense and work better?
Yeah, I remember hearing that analogy, and I loved it because it really resonated with me because in terms of thinking about where do we go next, part of the challenge that we face in Washington is we have people in that house right now who are accessing care and services in that house right now, but we also recognize that house needs to be significantly remodeled. And so how do you do those two things in concert? How do you provide services and care to people who need it today, yesterday, as well at the same time as building out a better house so that hopefully it functions in the future? And so, again, I think the JLEC is really designed to build on work that has been done before and is being very purposeful at looking at what are the prior recommendations, what's in progress, what haven't we done? There's plenty of recommendations out there that haven't been picked up. Why haven't they been picked up? Is there a policy reason, a fiscal reason? Is it not workable? And trying to move us along on that path on all of the work that's been done over the last decade.
I should also note that was a podcast that was done in partnership with the Seattle Times. I know kind of in the scientific community and the medical sphere, there are, that you can do original research where you're studying a problem and maybe you're doing a study, a double-blind placebo study. But there's also examples where somebody will step back and say, I'm not going to do my own research or individual research. Instead, what I want to do is kind of step back and look at all the research that's been done in a particular area, collate it, and then try to come up with what are the takeaways, what would the best practices be, what does the research say? Is there, and I wish I had the term for what that is, but is there an analogy to that sort of approach to what this committee is trying to do?
I think that's a great analogy because I think in many ways that's what this committee is trying to do. I don't think the committee is trying to reinvent the wheel or set us on a new path. I think the committee is trying to glean from what has been done before. Where are we and where do we still need to go? Because there have been a lot of recommendations that have been picked up. There's been really significant investment from the legislature over the last several years in behavioral health. It's been one of the top.
Billions of dollars.
Yes, billions of dollars. And so
and it's been a bipartisan priority.
100% it has, yes. It's been I think because everyone is touched by behavioral health in some way, either personally, family, friends, neighbors. It is a universal issue. And so I think that part of this is, with all that investment and with all that work, we are still seeing that the system is not working as it should for everyone. And so how do we really get there? How do we build on the work that's been done? How do we build towards filling the gaps that we're not yet filling? Or what are the things that we've started to fund that either we haven't done it in the right way or we need to keep moving forward on? I think that's part of what this JLEC is really tasked with doing.
Let me go back to the governor's announcement and transformation plan. The Seattle Times in April of 2023, so about a year and a half ago, when the 5 years was coming up, wrote a story saying 5 years later, the state has not met its goals that the governor laid out, and acknowledged that COVID interfered and that change happened slowly, and that there had been hang-ups to building more capacity for civil patients in the community. The governor had originally planned a number of 16-bed, or envisioned a number of 16-bed facilities in communities around the state so that you wouldn't even have to leave your home community to get care. Can you, sort of two thoughts on my mind. One is, why does it take so long to sort of meet these goals? And then maybe more importantly, what's happened in the intervening year and a half to get closer to reaching what the governor laid out, in that 5-year plan? But let's just start with that piece of COVID, setting COVID aside. Again, I think the frustration people feel is like, why does it take so long? And these leaders say, we're going to do this in 5 years, and then it doesn't happen, and it sort of feels like a setback.
Yeah, I might take a little bit of a different perspective on that in that I think a lot of things have happened. If you look at the amount of capacity that's been opened or funded in the last 5 years, it's a significant amount. And I also think that there's some truth to the fact that, as you build out this plan, the plan needs to be nimble and dynamic, and we have expanded into a variety of different areas. So I remember the original plan having sort of these concepts of 16-bed models. And I think part of what's happened is that there are some 16-bed models. There's a Clark County facility. There's a project with the Tulalip. They are some state-operated facilities. But there's also been investment in community provider-operated capacity through the Department of Commerce. The Department of Commerce has had quite a bit of money put to them for community behavioral health capacity grants, capital dollars that allow communities to come in and apply for money and to build out bed capacity in a variety of forms: crisis stabilization and triage facilities, intensive behavioral health facilities, peer respite facilities. And I think part of what the recognition is over the last 5 to 7 years is the need for that really broad continuum, that it's not just about building state hospital beds and community long-term inpatient beds. It's about building out all these other types of services because the need for behavioral health is not a monolith. People have all kinds of needs, and we have to have a diverse system that meets all those different kinds of things.
So what's happened in the intervening year and a half since the 5 years came up and the Seattle Times wrote the story about what kind of had not been completed? Can you sort of bring us, and again, I'm asking you to sort of wear two hats here. I know you're here in your capacity as the co-chair of this committee, but you also do sit in the governor's policy shop. What does the last 18 months look like?
Last 18 months is that we have had quite a bit of the state capacity that has either opened or is on track to open in very soon. You've had the opening of the new teaching hospital up at the University of Washington, which is one of the first of its kind in the country that does not only behavioral health capacity, but is designed to hopefully increase our behavioral health workforce in the state of Washington.
So you get more beds, but you're also then using that teaching hospital to train up the next generation of people to work in this field.
Yes, because as I'm sure you've heard before, one of the biggest challenges in building out behavioral health capacity is our behavioral health workforce. If we can build as many buildings as we want, but if we don't have the staff and the people to work there, the professionals to work there, beds don't do a lot for us. And so I think there's also been really concerted efforts in that space around increasing the Medicaid rates over the last several years for behavioral health providers. That's been one of the biggest things we've heard from providers, is that they need the rates to go up so that they can appropriately pay and provide good wages to their staff so that they can not only recruit people but retain them when they come into behavioral health. And so I think there's been a lot of work in those kinds of spaces that don't necessarily look like physical beds, but are so critical to the behavioral health system functioning in the way that it should.
Can you also update us on the forensic, the new forensic hospital at Western State Hospital?
Yeah, my understanding, and DSHS would be the best source of information for this, but my understanding is that they're scheduled to break ground on that new forensic hospital later this year. The legislature has provided funding to do that new 350-bed hospital, and so they've done the demolition work and the pre-work that goes along with it, and they're getting ready to break ground to get started on construction.
And one last question about this. So you said in some sense, as I heard you, what was realized over the last 5 years is that sort of the one-size-fits-all isn't going to work. Yeah, 16-bed facilities might work in some places, but you need to have kind of an array of options. What else it has and is coming online? For instance, remind us of what's gone on at Maple Lane, which I think is a former juvenile lockup facility or juvenile facility. What else has been established for civil patients in this state?
Yeah, so there's some capacity that has already come online on the Maple Lane campus.
And that's in Lewis County, I believe.
It is, yes, yeah, and there's a civil cottage that's come online there. I'm going to forget the name. I think it's Oak Cottage. There's been some conversion of some of the old units there. A lot of construction work and rehab work done by the Department of Social and Health Services to bring that online. There's a partnership between the state and the Tulalip to build a 16-bed facility up in that region. That's a civil facility. I think that's well underway. I'm forgetting the opening date of that. And that's all just state-operated capacity, which is different than, that's not the full universe of community capacity.
We've used the term behavioral health a lot. It's actually defined in the charter for this committee, but why don't you remind us of, when we talk about behavioral health, what that is as opposed to just mental health, which is sort of, or psychiatric care, which, I think oftentimes the terms get a little bit muddled.
They do. And one of the things I'd say is that actually I think that definition is a work in progress, and the Children and Youth Behavioral Health Work Group is also working on a definition of behavioral health. In fact, we just met last week to talk about how are we going to synthesize the work that the two group is doing so that we don't create multiple definitions of behavioral health out of these committees. In its simplest form, it's really thinking about mental health, substance use, well-being in a more comprehensive way. It's almost more like an umbrella term, whereas previously mental health or psychiatric care, you're really focusing on that mental health side. But I think behavioral health is more comprehensive than that.
The two ends of the continuum are really interesting to me. The deep end of the continuum that you often hear about is the people who cycle in and out and don't ever seem to really get better on a at least long-term basis. So based on the early, and I know it's early days yet, but based on what you know, what you're seeing in the conversations that are being had, is anything coming to light about how you could help? So, and we'll talk about getting to people earlier in a moment, but for those people that are sort of part of that revolving door, any best practices emerging, any thoughts about how to serve them better?
Yes, I think some of it's going to be what we're going to talk about later about intervening earlier and providing services. But for those folks who are in sort of the deep end system of care, it's about it's back to that array of options and making sure that there are a lot of options in sort of the less restrictive environment where people can move to once they have gotten sort of that deep end level of care. And that can be, not only build out of more long-term inpatient beds, but it's also things like there's been a lot of work in building out our long-term care system, our home and community-based services, things like our adult family homes, assisted living, those kinds of programs. We have a lot of folks who have developmental or intellectual disabilities, making sure that we have specialized service for them. They often sort of get swept up into the behavioral health system, which is not well suited to provide the care that they really need. And so how are we building out our intellectual and developmental disability system? Same is true for people with dementia, traumatic brain injury, some of those specialty services. I think there's also a really important role for the kinds of housing options we're providing in permanent supportive housing, low barrier, no barrier housing, those kinds of options that allow people to live more independently with wraparound services such as assertive community treatment teams, other kinds of teams that provide that support but allow people to live in more independent settings.
I know that generally there is absolute support for deinstitutionalizing serving people in the community, but I also know that there's pushback on the idea that the state hospitals would just serve forensic patients and not civil patients, because there are some very complex people on the civil side. And I've talked to community providers who say, look, we're not equipped to care for these people, or the community care facilities will pick and choose who they want, and they won't take the most complex cases. And I just wonder if there's any thought that the state has overcorrected in this sense, or what is the solution for those most acute, long-term civil patients?
Yeah, that's a great question, and it is something we wrestle with all the time, because we do see that there is some portion of the population that their needs are so high that they really need very comprehensive care in terms of what they need, and probably long-term care. And as you know, we have certainly seen that oftentimes that can be very challenging for our community providers to take on. And so I think there is probably always a role for our state institutions. The state has an obligation under our state constitution to provide care for individuals who have a mental illness. And so there will always be a need for that state level of care. But I think the important piece is figuring out how do we narrow the pipeline coming in to that level of state care so that people can receive care in the community when that is better suited to them. And then how do we make sure that the pathways out of state care are there and available so that people don't just sort of stall in our state hospitals. And, our State Department of Social and Health Services does a lot of work on this in terms of transition planning and other things, but they need to have the available in the community for people to go there. They can't plan in isolation.
Right. Okay, well, we're going to take a quick break. When we come back, I want to ask you about both some of the civil rights components to this and then also trying to do more early intervention to reduce the pipeline into this kind of acute care we've talked about. So we're going to take a quick break. When we return, we continue our conversation with Amber Leaders, co-chair of the Joint Legislative and Executive Branch Committee on Behavioral Health. Back right after this.
Stolen vehicles are a problem. We need a solution. Pursuits are not the solution to that.
Just hit another vehicle.
With the current pursuit law, you could literally have someone steal a vehicle and drive through a school zone actively at 100 miles an hour back and forth, and no one will be able to do anything about that.
Passing by school.
And welcome back to Inside Olympia. Joining me once again is Amber Leaders, co-chair of the state's Joint Legislative and Executive Committee on Behavioral Health. And I want to pick up where we left off with a question about balancing the civil rights of these individuals and patients with sort of the community imperative to get them the care that they need. I know that California has been looking at, and actually I think is lowering the bar, making it easier to involuntarily commit people. What is Washington learning from California? What's under consideration here as you think about balancing those sort of dueling needs and desires?
Yeah, it's always a real challenge when you're trying to balance those two things. We have looked at what California's doing a little bit, mostly in terms of the kinds of things that they're adding to their continuum of care, building out earlier diversion services, building out, we're doing a lot of work here on the crisis system, but they're doing work there as well, building out more of PAC teams, sort of community treatment teams, which are those wraparound community teams, and so we've looked at that. I know there have been some very recent conversations among community stakeholders about whether or not our Involuntary Treatment Act needs a revision and whether we need to rethink that. I think that's a worthwhile conversation to have about have we hit the mark in the right way. But I also want to say that I also really believe that so much of behavioral health care can be provided without being in an involuntary system. And I think the involuntary system really should be reserved for a limited number of individuals that really it rises to that level where, because the involuntary treatment is a pretty significant invasion on an individual's personal rights and personal liberties. And I think that should be taken very seriously, and that we should be using that tool only when it's most appropriate. And so part of that is making sure all the other array of services are available so that we don't fall back on that tool as just sort of an easy fix to getting people to care.
I think we've all read these agonizing stories about family members with loved ones, often adult children who are, in perpetual crisis and can't get them the help that they need, feel like the law creates all of these barriers and that they essentially need to become an imminent threat to themselves or others. They need to commit a crime. They need to jump off a bridge before the system will actually respond. And, those examples are all real life examples that I've heard personally of what it took to get someone help. But then there is the civil rights component and the fact that these are adults that we're talking about in this context. So just to put a finer point on it, or to go a little bit deeper, when you think about ways to serve those desperate families, short of amending the ITA, are there any specifics yet about what could exist tomorrow that doesn't today, or what exists today that didn't exist for some of these families a couple of years ago?
Yeah, and I've heard many of those really, really heartbreaking stories too. And what I see is that many times, not always, but many times, part of what's going on in the system is a response to the scarcity of resources available. So, for example, designated crisis responder goes out, responds to a call, and oftentimes they will have to make decisions about, is there a bed available? Do I have some place for this individual to go, or do I not? And so I think part of it is not only rethinking how we do involuntary treatment, which I do think is important and a conversation we should have, but I also think it's about how are we building out our workforce? How do we have enough designated crisis responders? How do we have enough early services so that people can get in when that phone call comes through? How are we building out our 988 system, our crisis stabilization facilities? That's such a critical part, that we need to have those locations where when people are in crisis, we have some place to take them. And that's what I hear a lot of times out of these stories, is that people have called numerous times, and because there's no place for them to go, they go deeper and deeper and deeper into their mental health until ultimately that's where they land up, is in these involuntary systems. And we should do a better job on that. We should be able to catch people much sooner than that.
The other thing you hear is the story of people cycling in and out of the hospital or out of drug treatment because they stop taking, whether it's medication-assisted treatment for addiction or their psychiatric medicines, which are keeping them stable, and then you're feeling okay, so you think you don't need them anymore, and you go off of them and you cycle again. And once again, you get to the situation of people's rights. Are we going to mandate that they take this medicine? Are we going to have somebody standing there supervising them, especially if they're not in a hospital setting? What are the conversations around trying to navigate somebody once they're stable so that they don't become unstable again?
Yeah, one of the tools that we have in Washington State that seems to be underutilized is assisted outpatient treatment. So on the books, under the Involuntary Treatment Act.
That was added a few years ago.
It was, yep, and amended. And there's been some resources dedicated to it, but we're continuing to find that for whatever reason, we don't have providers sort of fully implementing what is there. And part of the work that the Healthcare Authority is doing, and I anticipate this will be a conversation coming up in the next legislative session, is what's going on there? Is it a challenge with the way we've outlined the statute? Is it a challenge with resources? Is it a workforce issue? But to me, that's one of the tools that's available to us that we're not using nearly well enough, because it's an outpatient order, and it does what you're talking about, which is it provides some level of oversight and direction to an individual to live in the community. You're not in inpatient care, but you do have some requirements to take medications and do some other things. Medications often being one of the big requirements for assisted outpatient treatment. And so I think that's an area where we really could do some more exploration and figure out what's going on and why do we have this law on the books that's not being picked up.
And just because I don't want to lose sight of the fact that behavioral health is a big umbrella on the access, so we've been talking a lot about access to psychiatric care, access to drug treatment, especially because so much of it is medication assisted, so much of it does have to actually be supervised and doled out by an individual. You can't just send somebody home with the prescription. And we know it doesn't exist in a lot of counties in this state, and we're in the midst of a deadly fentanyl crisis, and this is a deadly addiction, and it's incredibly hard for people to get off of fentanyl, and that's why the medication is so important. what's it going to take to build out a robust drug treatment system in this state, concurrent to trying to also build out sufficient mental health services?
I mean, I think in many ways it's going to look similar, as you have to build out that full continuum of care that we need. And some of that is, getting more opioid treatment providers, providing dollars, making sure their rates are high enough so that they can actually operate their programs. We also, quite honestly, we need more providers, meaning medical professionals, to be willing to provide medication-assisted treatment. That's one of the things that we have seen sort of from the executive branch side, is that for a variety of reasons, there's oftentimes a reluctance to do that within their scope of practice, and we really need, because of the crisis you're talking about, we really need providers to step up and be willing to provide that medication-assisted treatment if they are able to do so. And we need to provide them the resources so that they can get that out there. We're also looking at all kinds of other interventions in terms of, there's long-acting injectables now that provide longer-term stabilization as people are going through recovery. We need to build out our recovery end of the system.
Because treatment is one thing, but there's a post-treatment element to this.
That's right, and making sure that people have access to things like recovery housing and other places for them to go once they've been through treatment. They're supportive, often they're peer-run or peer-led. That's really critical. There's been really some great investments in things like street medicine, the build-out of the health hubs, which are really centralized locations where people can get not only drug treatment, but also health care and other things. I think there's a recognition of, much like behavioral health, it's a holistic response that we have to have as we're thinking about people who are using substances.
You've just prompted for me also a thought that, you said earlier, it's been really hard for folks to get their arms around behavioral health because it's so big. But even if you manage to do that, and even if this committee could sort of create a roadmap for success for let's say the next decade, it seems like so much of what would predicate success is interconnected to other things for which this committee has no control and are also big intractable issues like housing. So I'm just wondering, is this committee capable of also starting to take into account these other legs of the stool that may not be directly behavioral health, but need to work in order for a better system of delivering behavioral health to work?
Well, so without my co-chair here, I definitely don't want to take on the issue of housing completely, but it's so critical.
And is that Representative
Representative
Sen? Yeah.
Yes, Representative Sen.
Yeah,
and so, but it's such a critical component, exactly as you describe. I mean, it's on that continuum for both mental health and substance use, is the need for housing, either permanent supportive housing or affordable housing, is really critical. I don't think the committee will take that on in terms of like a comprehensive review of the housing needs of the state, but I also think it would be hard for us to talk about our strategic plan without talking about housing and the role that it plays in the behavioral health system.
Okay, so we've spent a lot of time in the deep end of the pool. Let's go to the shallow end. And let's imagine somebody maybe it's a young person, starts to show some signs of schizophrenia. And you could imagine a system that ignores that person, and 5 years down the road, they are deep in crisis and are experiencing what we've sort of just laid out. But what if you could catch them earlier, get them the treatment they need, keep the disease from getting too acute, and get them on a trajectory to live and manage with that schizophrenia? What does a system that does that look like?
Oh, there's just so many different things that go into that. I think it's what kinds of behavioral health services are we providing in the schools? How are we supporting our schools to make sure behavioral health care is accessible not only to students, but so that the teaching professionals can identify and know, how to operate within the system? What are we doing for our young adults who are graduating from high school and moving on to college or other locations? How are we supporting our youth who are sort of our young adults who are 18 to 25? What are we doing for parents and for families to provide them with different kinds of education and resources and tools so that they can work within the system? I mean, there's just so many different ways in which we could expand that. It's hard to know where to start.
Well, and I want to go back also to workforce, because something you'll often hear from people is it's so hard to get in to see a mental health professional. It's almost impossible to get in to see a psychiatrist. It's often hard to, if your child is having maybe an initial break, it's hard to see a psychiatrist who will treat that, you know, whose scope of practice includes treating a young person in crisis. So all of these barriers to entry, and then, oh, by the way, do you have health insurance? Is health insurance going to cover it? So it seems like we throw up all these roadblocks for families, even those families that are trying to get their loved one help. And I know you mentioned the teaching hospital, which is supposed to help address some of these workforce issues, but I mean, psychiatrists alone are in such short supply, and they're the ones who can prescribe.
They are, and everything I know is that I think you're seeing fewer and fewer medical students going into the psychiatry profession. It's an area that we really have got to boost in terms of workforce. I think some of that can also be, you know, how are we having a diverse workforce of prescribers? You know, there's been an increase in our ARNPs, advanced registered nurse practitioners who can be prescribers. And so I think that's one of the ways in which we can think about that. I also think the integration of behavioral health into primary care, which is some work that's been in progress now for a number of years, is really critical to that, because ideally, part of what's happening is that, you know, those youth, they're getting their first touch point from their pediatrician, from their primary care doctor, and that we're trying to provide some of those interventions and services earlier so that you don't necessarily have to see a specialist, and that if you do need to see a specialist, then we need to make sure that those individuals are available.
Is there, you know, I think in some respects I'm just seeing a bunch of dollar signs piling up here. And as we've noted, the legislature has already put, you know, it is, I think, billions at this point, more into this system. When all is said and done, and there will be a final report from this committee, I don't expect you to put a dollar amount on it right now, but prep us for, and if there's a legislator or two watching this or listening to this, what's the reality, and I know there are also legislators on this committee, but like what's the reality check about how much more investment is going to be needed?
Well, I think it's significant, but I also think that there's been so much investment over the last several years that I don't think it's a duplication of what we've already done. And I think that's part of what the JLEC is tasked with, is how do we strategize and best invest for the next steps into the system? What do those look like? Where do we really need to fill those gaps? But I don't think anyone should expect that it's going to be inexpensive to do so. I mean, but it's important. It's so important for our community, as we talked about earlier. It touches on everyone in Washington State. And so it's just an area that I think the investment is really critical. But I don't think it'll be inexpensive.
Yeah. And in many respects, the state has been digging out from a hole we dug ourselves over decades by not adequately investing, and trying to get ahead of things is taking time. So progress has been made. None of this is going to happen overnight. And we've got a big deficit that we're sort of digging out of.
Yes.
I want to hit a few more points and issues in the time we have left. One is to put a finer point on 988 as a new resource for those in crisis. Why do you think that's such a potential game changer?
So 988, Washington State has taken a really ambitious approach to 988. So 988 was the national suicide hotline. The federal government sort of put out that we were going to transition to this 988 three-digit system. And Washington State has not only done that, but is proposing pretty big reforms in terms of how we do crisis response, as well as providing services to those individuals who call into 988 with next-day appointments and other things. And so one of the things that I think is really important is that it anticipates a build-out of our crisis system, not only having the line, but having the place for those individuals to go. There's a fairly small percentage of people who call into 988 actually need a dispatch of some time, a mobile crisis response. But for those individuals that do, how do we make sure that when the responders go out, that there is a place for that individual to go after the response has come out there? And I think what 988 is doing is building out exactly that that system.
So the concern would be you'd create a number of people can call, but there's no real resources on the back end. But what you're saying is you think Washington State is doing a good job of building the response and the services that are needed for the people who might avail themselves of this new telephone number.
Yes, I think Washington State is doing a very good job on that, and I think it's a pivot in terms of how the system has worked. You talk about the deep end systems, for a long time. I mean, the way to do that is to call 911 and have a law enforcement response come out. Now, there's been a lot of work to have co-response teams, social workers, clinicians ride with law enforcement, but I think even if you talk to law enforcement, most would say for a behavioral health call, there's better ways to do that, either with behavioral health clinicians, with fire, with EMS. And so I think part of what we're also building out is bringing out the right teams when a call is needed, and so that you are doing more of that diversion into the treatment system rather than into the emergency room or the criminal justice system.
I also want to ask you about the Trueblood case, which was, I think, a class action lawsuit, but brought on behalf of people who were languishing in jail because they could not get into state hospitals for competency evaluations, and then if they were found not fit to stand trial, competency restoration. Something I reported on extensively, these very tragic stories of people just waiting and waiting and waiting. So there's a lawsuit, and then the federal judge said to the state, here are the timelines you got to meet. And I think it was 14 days for the eval and 7 days after that if it found not competent to get into the hospital to get a bed. For years, the state wasn't compliant, accrued huge fines. But just this month, it was announced that for the first time, the state was, at a point in time, at least with those two examples, the timelines for getting people services, compliant. So I'll let you reflect a little bit on that milestone. And again, it could change because there was just a moment in time. But what is the significance of getting to this point?
Well, it is a huge milestone for the state, and there's been incredible work that's been done by our state agencies, both Department of Social and Health Services as well as Healthcare Authority. DSHS has built out a tremendous amount of capacity over the last several years. And I've heard some of the staff there really talk about, it's been a multivitamin approach, and it's been the work of years to try and get to that place, building out not only bed capacity, but there's been additional investments in things like diversion resources, building out outpatient competency restoration, things like forensic navigators, which are individuals that help navigate the system for people who have those behavioral health needs who are caught up in competency. And so there's been all these different pieces that have come together. And it is a great accomplishment. It is, as you said, a point in time, and we need to maintain that going forward. And one of the things we've seen over time, if you look at the data in Trueblood, when the case first started in 2014 or so, DSHS was getting about 3,500 referrals per year. They now get about 8,500 referrals per year. And so some of this, the legislature has made incredible investments to be able to respond to what's been going on in Trueblood. But we also need to continue our work to figure out how do we bend that curve downward. We still have far too many people with behavioral health needs going through the criminal justice system, and I'm really happy that we can respond to those who are there. That is an accomplishment so that people aren't waiting for services. But we also need to keep working towards having fewer people go through in the first place and making sure they're getting their access to care out in the community rather than coming through criminal justice at all.
Which goes back to the diversion point you were just making. Mm-hmm. Is there a reason that anybody has pinpointed or identified why the numbers have spiked in that fashion? What's going on?
No, there's been a number of looks. The court has looked at this as well. People have sort of tried to pinpoint, and you see little spikes here and there. So, for example, with the expansion of the ACA, when you had more single males going on to Medicaid, there is a little bit of a spike. And the theory there is that you have more individuals who previously weren't accessing the system at all sort of starting to access the system because they have access to Medicaid. You don't really see a change in the number of prosecutions happening, because that's one of the first things we looked at is that, well, if prosecutions gone up, because that would make sense, but that really has in many ways stayed flat. And so you see a little bit of a fluctuation during the COVID years where there's a dip and then a pretty big spike as we come out of COVID, because some of that's due to the backlogs that courts and others experienced. And so the long answer, I guess, is no. We don't know for sure what's led to those increases, but we know they happen, and we know not only do we have sort of a steady increase in the number of referrals, we get these blips where there's really significant increases for a short period of time. And those blips, those ones where we get really big increases all at once, are the hardest for the state to weather. And that's one of the things we have to figure out how to predict a little bit better.
Right, because that could set you back on your compliance. What is it going to take to be fully compliant with True Blood? What's outstanding at this point?
Yeah, so it's you have a couple of things in True Blood. So you've got the original constitutional timeline that the federal court set, and that that we'll need to comply with at a very high level for probably some period of time. Unclear how long the federal court might want to keep an eye on that.
Keep jurisdiction of,
Yep, keep jurisdiction, but I would anticipate for some period of time. We've been out of compliance for a number of years. She probably will want to watch for some period of time. You also have the settlement agreement that's in place, which is really a settlement of the contempt that was in the case, and that has a build out of a number of different items. That's all the things we talked about: the forensic navigators, outpatient competency restoration, some diversion services, and that also has some compliance factors in it as well. That the state has to continue meeting as we go forward. And within that agreement, I don't remember the time frames off the top of my head, but it does talk about the number of months that the state needs to be in compliance with the constitutional timelines in order to move away from that settlement of contempt. So we are doing great. It is a really, really huge milestone, but we need to keep working on it.
The skeptical side of me, I remember when the lawsuit and conversation was around emergency room boarding, where psychiatric patients were sitting in the lying in the hallways with nowhere to go. And now, 15 years later, I'm guessing, that still happens. And, in some respects, it seems like we never fully solve these problems, or they come in cycles. So whether it's True Blood and forensic patients languishing in jails or patients languishing in the ERs, what can you say to the community, to families, about these kind of seemingly never-ending problems with this system?
Yeah, I think one of the things I would say is that there is work going on. It may not always feel like it, because I know on an individual level that there's a lot of families still experiencing this, but there has been a really significant effort. The governor has really prioritized behavioral health. The legislature has provided, as we've talked about a number of times now, really significant funding. And I think there's a recognition from all involved that there's more work to be done. And so I don't want anyone out there to think that everyone's, sort of resting on their laurels and saying, well, we've solved it, we're good, we've invested all we need to, because I don't think anyone who works in the system would say that. And some of this is the work that the JLEC is doing, is how do we, with all the investment and all the work that's gone on, and seeing progress but not being where we want to be, how do we really get there, and how do we take those steps? I mean, I think that's what is really on deck, is how do we really get there to the outcome that everybody wants us to have?
I just want to note that there's this other group focusing especially on children and services to children, which is a whole other issue and challenge in this state, getting kids the services they need. Just in the less than a minute we have left, what will success look like for this committee as you do your work? And reporting back in 2025, right?
Yes, reporting back in 2025. I think for me, success of this committee will look like two things. One, that we get through the work and that we provide a comprehensive report that has buy-in from the community that people support, and then that we act on it.
So a roadmap that gets implemented.
That's exactly right. Too often we have reports and recommendations that go and sit on the shelf somewhere, and so I think real success is we got to act on it. We've got to make a move with whatever we come up with.
Okay. Amber Leaders, co-chair of the Joint Legislative Executive Committee on Behavioral Health, also a senior advisor in the office of Governor Jay Inslee. Thank you so much. Appreciate the conversation very much.
Yeah, thank you.
And thank you for watching Inside Olympia. We will see you again next week.